Due to circumstances, I cannot use a couch, so some of the musculoskeletal assessment will be filmed on the floor. I've ensured my hands are thoroughly washed, my hair's tied back and my nails are cut down to the correct length. Before starting the film, I have asked my client contraindications, some of which are acute inflammation, early stages of healing, cancer or previous cancer, constant pain progression, inability to lie, supine, and any unwell feelings. And I've also asked red flags, but on my Word document you can find this in my reference list. So the next part of the assessment is observation. So I'm going to ask my client to march on the spot for me and then stop. And this is going to be static observation. So first I'm going to look at muscle bulk. So predominantly because we're doing the quads, I'll look at the, because we're doing the knee, I'm going to look at the quads, just check if one's bigger than the other. This could mean there might be an injury, so the other one's compensating for it. Yeah, both look fine. And then we're going to go on to soft tissue. So looking around the knee, seeing if there's any swelling, any coloration, any scars or anything like that. And then we're going to have a look, because it's the knees, have a look if the knees turn inwards or outwards, so valgus varus. If it turns inwards, it's because of weakness of the glutes. So there is they slightly do turn in. Next, we're going to have a look at the knees and see if they are level, so in themselves. Okay, and then just a quick overview of the feet. Check the arches, quite low, and her feet do turn out slightly. Done as a Q angle. This will show you the quadriceps muscle force. So you need to make sure the feet and the hips are all in a neutral positioning, and then you need to draw a line from the AIS of your client to the midpoint of the patella and then to the tibial tubercle. Okay, its data shows that a male's Q angle should be 13, female's Q angle should be 18. This was said in McGee 2014 orthopedic physical assessment. Doing static observation, due to circumstances, I would normally, the therapist, move around my client, but because of filming circumstances, I'm going to ask my client to turn around for me. So this is going to check the posterior part of the body. So firstly, just looking at the spine, seeing if it's all straight, just making sure that there's no signs of kyphosis or anything like that. And then coming back down, I'm going to check muscle bulk again. So again, your hamstrings, and then your gastrocnemius. And then again, looking if there's any swelling behind the knee or any coloration. So next is dynamic assessment, observation of the client. So I'm going to ask them to walk up and down and while I assess them. Okay. So first you're looking at their feet, seeing if they pronate or supinate. Seeing their step and stride length is key. So step length is if the distance taken in one step, and stride length is the distance taken in 2 steps from the same foot. Step and stride length will be different in people once calculated, because factors like gender, height, weight can affect this. But if each stride length changes from one foot to the other, there could possibly be a problem in their kinetic chain. Okay, so now moving up, we're going to have a look at the knee to see if there's any hyperextension at the knee, any external or internal rotation at the knee, if there's too much flexion at the knee, seeing if they, when they walk, they're limping, but my client seems to be okay in all of that. Clearing the joint above and below, so for below it's going to be the ankle. So I'm going to ask my client actively to plantar flex their foot for me, lovely, as far as you can go, and then dorsiflex, okay, and then inversion for me, okay, and then eversion, lovely. So now it's going to be passive, so I'm going to apply some overpressure. So plantar flex for me, okay, and then dorsiflex for me. Okay, and then inversion, sorry. Lovely, and then eversion for me. So the purpose of this is to see if there's any referral of pain. Okay. Next is going to be clearing the hip. So this is the quadrant test. So first I'm going to lift the knee up into flexion, put my hand underneath the ankle and the other on top of the knee. So when I apply pressure through the knee, it'll put the femur into the acetabulum, and then I will rotate it through all range of movement. Like so. If the client feels any pain, this will test positive. If the therapist can feel a hard end feel, so bone on bone, this will also test positive. So next is palpation. I'm going to look at the knee itself, first by looking at the patella, starting at the apex, moving up to the base. You're looking at applying a lot of pressure into the palpation so you can find any problems. Next, going to look at the medial condyle and move across to the lateral condyle. And then move down to looking at the tibia tuberosity and the patella tendon. And then moving out to find the head of fibula. And then with the head of fibula, you can move into finding the lateral collateral ligament. And this is a short band of tissue. Then you can find the quadricep tendon, to then move into finding the medial collateral ligament, which is a broad, flat band of tissue. So during palpation, you need to palpate the muscles as well. So starting with the quads, you want to palpate vastus lateralis all the way down, and then rectus femoris, as well as vastus medialis. You can go into the abductors. And at this point, I'd ask my client to go into prone so I can check their hamstrings, their gastrocnemius, their glute med, and also their TFL moving into the IT band. Next is range of motion. So I'm going to start with flexion and extension. So can you do active flexion? So bring your heel to your bum for me. Lovely. Okay, and then extend it for me. Brilliant. So now it's going to be passive flexion. So bring your heel to your bum for me. And you're just going to apply some overpressure. This will be soft tissue approximation, but it should go to about 130 degrees roughly. And then for extension, passive extension is just bringing the heel up and extending. Okay, so now resistive movement. So you can bend your knee and then try and take your heel into your bum for me. Keep going. Lovely. Okay, and then bring it back down, and then can you drop this leg down for me? And then for extension, please lift your leg up into extension for me. Brilliant. Next is active range of motion for internal, external rotation. So can you internal rotate your lovely and external for me? Brilliant. Okay, and then internal. Okay, and external. Lovely. The Oxford scale is using during range of motion. It's used to identify the client's muscle strength. Therapists will identify the muscle strength on a scale of 0 to 5, 0 being no movement, 1 being a flicker of movement, 2 being going through a full active range of motion again with a counterbalance, 3 going through a range of active motion against gravity, 4 a range of motion with some resistance, and 5 a range of active motion against a strong resistance. So there are some limitations of the Oxford scale. Over time, the client could obviously be fatigued, which will alter the results, rather than if it's obviously to come out as a 3, could indicate that's fatigue, not because of an injury. My client could do all the movements with strong resistance, therefore she comes out as a 5. So next is going to be manual muscle testing. So I'm going to do the straight leg raise, which will, so if you lift your leg up for me, this will test the hamstring muscle, and then if we dorsiflex the foot slowly, this will put the tibial component of the sciatic nerve on stretch, and if they feel any pain, they should be referred. Next part of the musculoskeletal assessment is special tests. Special tests are used to confirm or deny that the client has the problem, injury or disease. There's 4 results which come out of it. There's true positive when the client has the disease and tests positive, false negative when the client has the disease but shows negative, false positive when the client doesn't have the disease and shows up positive in the test, and then true negative when the client does not have the disease and shows negative. Next is the Lynchman test. This will test any instability of the knee. So I'm going to put my thigh underneath my client's, and then I'm going to hold on top of the femur just above the patella and hold behind the tibia and just push it forward and see if there's any pain. If a client tests positive of this, you will feel a soft Enfield, and this detects the ACL. Posterior jaw test. So ideally you want to sit on the client's foot like so, place your arms around the back and put your thumbs on the patella, and in an explosive movement you're going to drive the tibia back posteriorly. If it's positive, you should feel a soft Enfield, or it should be moving back more than 6 millimeters posteriorly. The instability tests for the knee do different roles. So the Lynchman test will detect a tear of the ACL, whereas the posterior jaw test will detect a tear in the PCL. So a therapist should consider doing all of them if they don't know what the injury is at the time, so they can rule out every possibility. The next test is the Thessaly test. This test is from the menisci. After research, I found that this test should be the best because it helps with the sensitivity and specificity part of it. So for the test, I'll ask my client to lift up this leg, please, and then go to a 20 degrees flexion of the knee. Okay, they can hold on for me for support, and then I'm going to ask them to internally and externally rotate 3 times. They're test positive, there's a referred pain, or there's a sense of catching and locking, and it replicates the loading process of where pain could be. Further reading shows that overall in the menisci test, the diagnosis can be quite poor. There is a 20% false positive results in all 3 tests. This data should be used with caution because of the research paper did have a low quality of study in it and a high level of heterogeneity. And although throughout the research years the sensitivity and specificity has altered, increasing and decreasing, so you should always use the most recent research papers to find all of the appropriate sensitivity and specificity. The next test will be for other structures. This is going to be the patella tap test. Okay, so with downward stroke, you're going to apply downward pressure onto the base of the patella, and the same going upward stroke, apply downward pressure on the apex, and then with one finger you're going to just tap the patella, and if it's floating it means that there's been fluid underneath it, and this could cause swelling for the patella joint. My client's going to put a finger on the wall and lift the uninjured leg up and hold this for 30 seconds. Test positive if they feel any hip pain and if they keep wobbling and inversion and eversion of the foot.